Welcome to this explainer. Today, we're rolling up our sleeves and embarking on a bit of a medical detective journey. We are going to unpack the objective cardiovascular assessment. You should really think of this as more than just a routine medical exam. It's a highly systematic investigation where every single sound, every pulse, and every shadow on the body gives us absolutely crucial clues about that incredible pump keeping us all alive.
Here is our roadmap for systematically investigating the body today. We'll cover setting the clinical stage, clues in the neck vessels, palpating the anterior chest, the art of auscultation, spotting heart failure signs, and finally, the ABCs of heart health. Let's dive right in.
Section 1. Setting the clinical stage, preparing the patient and room. A really successful exam absolutely starts with the right environment. We need a scrupulously quiet, comfortably warm room with our patient resting flat on their back, elevated at about a 30 to 45 degree angle.
Now notice the specific sequence we follow here. We utilize a very strict choreography for a regional cardiovascular assessment. We move step by step from the pulse and blood pressure to the extremities, down to the neck vessels, and finally end up at the precordium, which, if you aren't familiar, is just the area of the chest right over the heart. So the underlying logic here is pretty brilliant. We begin our observations peripherally, way out at the edges, and move steadily inward toward the heart itself.
Okay, Section 2. Clues in the neck vessels, carotids and jugulars. Let's look at the vital external clues these specific vessels can give us about the heart's overall efficiency as a pump.
We actually start by grabbing our stethoscope and auscultating, or listening to, the carotid artery, specifically hunting for something called a bruit. A bruit is this blowing, swishing sound that indicates turbulent blood flow, and it serves as a major red flag, a marker for atherosclerotic disease. When we do this, we'll ask the patient to briefly hold their breath so their normal breathing sounds don't mask the bruit. And this is critical. We are incredibly careful to palpate gently and only listen to one side at a time, no exceptions. We absolutely do not want to compromise arterial blood flow to the brain.
Next up, we inspect the jugular veins. Think of these as a built-in pressure manometer attached directly to the right atrium of the heart. We're looking for the highest level of venous pulsation and comparing it right to the sternal angle on the chest. Normal jugular venous pulsation should be less than 3 centimeters above that angle. If it's higher than 3 centimeters when the patient is sitting at that 45-degree angle we set up earlier, well, that signifies increased central venous pressure, which is exactly what we see in conditions like heart failure.
Now, because the jugular veins and carotid arteries lie so close together in the neck, it is super easy to get their pulsations mixed up. We have to differentiate them. The internal jugular pulse has this undulant, diffuse quality with 2 visible waves per cycle, and its level actually drops when the person sits up. Contrast that with the carotid pulse. That one is a brisk, localized, single-wave pulsation, and it is completely unaffected by the person's position or their breathing.
Moving on to Section 3. Palpating the anterior chest, investigating the precordium. Now we're moving inward to literally feel the mechanical thrusts of the beating heart beneath the ribs.
Our primary target here is localizing what's called the apical impulse. This is the physical pulsation created as the left ventricle rotates and taps against the chest wall during systole. It should feel like a short, gentle tap, occupying just one intercostal space, usually the 4th or 5th. We take a moment to precisely measure it. Normally it's about 1 by 2 centimeters. But if we find an enlarged diameter, say 4 centimeters or more, that's a huge clue. It tells us we might be looking at a dilated heart resulting from volume overload, like you'd see in heart failure.
After finding the apical impulse, we palpate across the rest of the precordium using the palmar aspects of our fingers. We're searching for any abnormal pulsations, but particularly we're looking for a thrill. A thrill is a palpable vibration. To put it vividly, it feels exactly like the throat of a purring cat. If you feel a thrill, it immediately signifies turbulent blood flow and literally directs your hand right to the origin of loud, underlying heart murmurs.
Section 4. The art of auscultation, listening to the valves. Now it's time to use our stethoscopes to uncover the deepest secrets of those internal valves.
First things first, we start our listening by establishing the heart rate and rhythm. A normal resting rate ranges from 50 to 95 beats per minute. We're also checking for a nice, regular rhythm. Though it's worth noting that a sinus arrhythmia, where the rhythm speeds up and slows down slightly with breathing, is actually perfectly normal in young adults and children. However, if we hear an irregularly irregular rhythm, where beats are just coming rapidly at totally random intervals, we must check for a pulse deficit to see if every single beat is actually making it all the way to the periphery.
Next, we absolutely must confidently identify S1 and S2. This is the classic lub-dup.
This step is foundational. S1, the lub, happens when the AV valves close, and it's always loudest at the apex, the bottom tip of the heart. S2, the dup, is from the semilunar valves closing, and it is loudest up at the base. Identifying these sounds is crucial because they beautifully serve as our temporal reference points, allowing us to accurately map out the exact start of systole and diastole.
So we have our normal lub-dup. But hey, what happens when those normally silent periods of the cardiac cycle are suddenly interrupted by extra hidden sounds? This is where our detective work gets really nuanced.
We might actually run into a third or fourth heart sound. An S3, often called a ventricular gallop, happens in early diastole. It's this dull, low-pitched sound. Honestly, it sounds a bit like distant thunder. In adults, it indicates decreased ventricular compliance, and it can potentially be the very earliest sign of heart failure. On the other hand, an S4, or atrial gallop, occurs very late in diastole, right before S1. That happens when the atria are forced to contract against a stiff, non-compliant ventricle.
While we're listening, we're also on high alert for murmurs. A murmur is a blowing, swooshing sound that happens when there is turbulent blood flow within the heart or the great vessels. Now, a systolic murmur can occasionally happen in a totally healthy heart, and functional or innocent murmurs are actually pretty common in healthy youth because their blood is flowing at a higher velocity. But generally speaking, and especially if it's a diastolic murmur, these swooshing rivers of turbulence are markers of abnormal, pathologic heart disease.
When we do detect a murmur, we meticulously grade its loudness on a standardized 6-point scale to track its severity. A grade 1 murmur is barely a whisper, hard to hear even in a completely quiet room. It scales all the way up to a grade 6, which is extremely loud. In fact, it's so loud you can hear it with the entire stethoscope lifted just barely off the chest wall. And a grade 6 is always associated with that palpable frill, that purring cat sensation we talked about feeling earlier.
Section 5. Spotting heart failure signs, the clinical portrait. Let's piece together what it looks like when the heart actually starts failing as a pump.
Heart failure triggers a really dramatic chain of symptoms stemming from two main things: the heart's inability to pump enough blood forward, and the kidneys abnormally retaining sodium and water to try and compensate. This leads to a massive cascade of systemic issues. We see shortness of breath, pale skin, that jugular vein distension we measured in the neck, an S3 gallop on auscultation, decreased urine output, and dependent pitting edema in the legs as fluid literally backs up into the body's tissues.
And finally, Section 6, the ABCs of heart health, prevention and promotion. It's time to pivot from medical detection to active, lifelong prevention.
We advocate for what we call the ABCs of heart health. A is for considering appropriate aspirin therapy, which is based on your specific age and risk score. B stands for strict blood pressure control, aiming for routine checks every 6 months. C is cholesterol control, meaning screening yearly for LDL. S stands for smoking cessation, arguably the absolute biggest thing you can do to protect your heart. And finally, embracing small lifestyle changes. Eating a heart-healthy diet, aiming for just 30 minutes of exercise 5 days a week, and keeping your weight in a healthy range.
Well, we've covered the complete journey today, from assessing the neck vessels and the chest, to listening closely to the intricate sounds of the valves, right down to the systemic signs of heart failure and exactly how to prevent it. As we conclude this explainer, I want to leave you with a question. Which of these brilliant preventative steps from the ABCs can you prioritize and take action on right now to protect your own heart's rhythm? Thanks for joining me on this investigation. Keep learning and keep protecting that incredible pump.